Hello and welcome to this video presentation of our paper called Choosing the Right Reality, a comparative analysis of tangibility in immersive trauma simulation, which I'm going to present on behalf of my wonderful co-authors. This work is nested within the MedFirst MR project, which was a Horizon 2020 EU project, which ran for 3 years and just ended in May, with the aim of developing a mixed reality training solution for medical first responders to better prepare them for stressful and highly complex situations during their job. The need addressed within the project was a general increase in crisis situations, and thereby also the need for medical first responders to be better prepared to train more often for these often unlikely but real situations that can happen. We identified the status quo of training methods, which is on one side training on simulation mannequins, which allows for some skill use and skill training tools. And on the other hand, in recent years, virtual reality trainings have become more prominent. Both training modalities have their distinct advantages and disadvantages. Traditional training on mannequins or other role players typically involves the use of real tools and is very hands-on, but maybe lacks some environmental realism and immersion. Virtual reality, on the other hand, can provide exactly that, but is limited in terms of tangible interaction and is more focused to learning certain methods and certain procedures rather than the actual skills. This is where the MedFirst MR project came in. Here we had the goal of developing a mixed reality solution involving tangible tools in the sense of augmented virtuality to provide the best of both worlds. This was achieved within the project with two distinct training systems. On the one hand, we have a multi-user triage training, which is largely virtual reality. And on the other hand, we did some research and prototyping in the direction of mixed reality, including tangible tools, which I'm going to talk to you about today, which is actually the picture in the MR approach. First, let me give you a bit of an overview of the process we went through within the last 3 years. Actually, this work builds upon a paper published at SIGCHI 2023, where we described everything in the first stages of this process, which involved an intensive requirements phase at the beginning of the project, a creation of virtual environments, scenarios, and patient personas. From there on, we went into an ideation phase, built a first prototype, and did a first feasibility user study. And all of this is in the paper presented at SIGCHI 2023, called Tangible Immersive Trauma Simulation. In this work, we build upon this first paper and this initial evaluation by showcasing our improvements we made following the feedback from the first user study, and we present a comparison study where we compare mixed reality, virtual reality, and real training in terms of the effects the modality has on the user experience. So let's get straight to the point. This is the mixed reality mannequin prototype we built within the last 2.5 years. First of all, the mannequin is painted green as we use a chroma keying feature of the Vario XR3 mixed reality headset, meaning that everything that is green can be keyed out, everything that is not green is overlaid on top of virtual content. So this means that the patient is a virtual patient, but also haptic. This also means that the users or trainees can see their own hands and can bring their real tools into the mixed reality simulation. And the thought behind that was that this would enable actual skills training in a very immersive environment. On the left, you can see how this looks like from the outside with a medical first responder using a ventilation bag to assist the respiration of the patient. On the right, you can see how this looks like from the participants, from the trainees' view. So the hands and the tools are overlaid on top of the patient, and the patient is virtual, but the haptic feel is still present because it's a mannequin, the Green Manikin. The whole scenario and environment was programmed within Unity. We developed a little demo scenario to test the capabilities of the system. In the demo scenario, there was a car accident involving a bus and a cyclist, and the medical first responder arrives at scene and has the job to care for the cyclist, who's lying on the floor, breathing heavily. The first responder would then see a large wound on the knee of the patient, and this would prompt them to use a tourniquet to stabilize the blood flow from the knee. Afterwards, the job of the first responder was to check the vitals of the patient, for example, using the stethoscope or using an oximeter, which was both using real tools. And later, when the state of the patient decayed, using the ventilation bag to assist in respiration. This was a little vignette scenario which involved the use of free tools, which we developed to test and experiment on the users within our studies. Our main question after finishing the mixed reality mannequin prototype was how our solution would compare against A, traditional forms of training, including a role player, and B, how it would compare to virtual reality trainings. And to that end, we designed the same scenario in the mixed reality condition in two different modalities. We basically did an exact copy of the scenario in virtual reality and in a real simulation training involving a role player and the use of the real tools, but only in a simulated manner. For the study, we had two main research questions. A, how the three modalities would compare in terms of acceptance and also in terms of presence. The second research question was which modality is the most beneficial for which specific training goal. The aim here was to generate a mapping of modality towards training goal and to thereby help future designers and developers in developing trainings for first responders. The methodology here was rather simple. We had 3 stations in our lab, one with the real training, one with the virtual reality training, and one with the mixed reality training solution. We did a counterbalance design with a total of 15 medical first responders. And after each station, the participant answered a questionnaire on technology acceptance and on presence, and also answered a couple of open-ended questions regarding qualitative feedback towards the respective modality. Our main interest was how the interactions with the tools and the patients were conducted in the 3 modalities and how they would compare in terms of acceptance of the training and in terms of realism and presence. In the real simulation training, an experienced role player participated in the study who was briefed exactly with the information that the virtual patient would also have. A wound was placed on the leg to simulate the bleeding wound, and all information about respiration rate, about heart rate, etc. was given by a trainer sitting nearby on request of the medical first responder, which is a classic way of training for these situations right now. In mixed reality, this was done accordingly, but on the mannequin, of course. Here you can see how it looked like for the participants to put on the tourniquet, to listen to the internal lung sounds with the stethoscope, and to use the ventilation bag in the end of the scenario. In virtual reality, we used the MetaQuest Pro and the included hand tracking feature. The tools were all completely virtual and could be picked up with the user's hands and placed on the respective locations and thereby trigger the respective reactions, like playing the internal lung sound or ventilating the patient. So let's take a little peek into the results. Firstly, regarding presence. For physical presence, we didn't find any significant differences between the 3 modalities, although the rankings imply mixed reality as being highest here when you look at the means. For self-presence, we actually found a significant difference between mixed reality and virtual reality, which suggests that mixed reality provides a stronger sense of self-presence, i.e. really being there with your own body, which is plausible as the own body was visible and was the main way of interacting with the environment. Self-presence in virtual reality was also significantly lower than the real condition. So we have a nice split here between virtual reality on the one side and mixed reality and real training on the other side, with MR and real training feeling much more self-present than virtual reality. Regarding social presence, we found that mixed reality was significantly higher rated in social presence than virtual reality, which means that just by including this haptic mannequin, the illusion of being with another person increases significantly. Of course, real training was the highest here as there was an actual person lying there, but it's a good sign that mixed reality can bridge the gap between VR and real training. Looking at the technology acceptance scales from the UTAU-2 model, we can see a high significant difference in effort expectancy, which indicates variance in perceived ease of use, with the real training being perceived as the most easiest in terms of effort when compared to mixed reality or virtual reality. We did find significant differences in facilitating conditions. So the perceived support for training in the modalities was actually higher in real and mixed reality condition than in the virtual reality condition. Regarding behavioral intention, we did not find any significant differences among the modalities. So there's a similar intention to use the systems. If you look at the graphs though, a clear ranking emerges. In future studies, it would be interesting if an effect actually appears when we look at the broader sample size. Regarding the qualitative results, we asked the participants in the questionnaire which training modality they would prefer to use on a daily basis. And actually, most of the participants stated that mixed reality is the one they would use, with only one person saying virtual reality and 3 persons saying the real simulation training to be the preferred solution. We also asked them about their overall impressions with the systems, which we have summarized very shortly here. To be succinct, real simulation training is the established training variant, but is very limited in its complexity because you can only do so much with a role player, and it's not very immersive. VR has great potential for leadership training, for making decisions within a virtual environment, but needs some improvements in terms of interaction with the patients. Mixed reality, on the other hand, was highly favored for its realistic simulation and integration of real and virtual elements. So exactly the goal we had in mind at the beginning of this. Coming back to research question 1, how the modalities compare in terms of presence and technology acceptance, we can say that results show that mixed reality really stands out as like an optimal blend between virtual and real, achieving high marks in both presence and technology acceptance and usability, nearly on par with real training on many of the scales. The mixed reality condition also surpassed virtual reality in basically all of the scales we looked at. Concerning research question 2, which was about which training modality fits best with which training goal, we can see that each one of the modalities has certain strengths. Mixed reality really has its strength in the mixture between high environmental realism and depicting these stressful and complex situations with the actual hands-on skills training with the use of real tools in the virtual environment. This is ideal then for scenarios involving a complex scenario, a stressful scenario, where also actual skills need to be trained. Virtual reality, on the other hand, excels in organizational training and continuing education. In virtual reality, processes can be trained very effectively, the order of things to do, but less the actual hands-on experience. This is also why many of the participants mentioned leadership training as being ideal for virtual reality in these situations, as this involves a lot of decision making and perceiving the stressful and threatening elements in the environment. Real training was mentioned as still being a crucial training modality in the curriculum, as it gives you hands-on experience and lets trainees build muscle memory and basic skills, especially in the beginning of their career. So to recap, we built a mixed reality training solution using chroma keying and a mixed reality headset and compared it against virtual and real training. The mixed reality training solution actually emerged as the most promising of the three, combining high presence and high intuitiveness by including real tools. In the future, it would be interesting to conduct more longitudinal studies, looking also at the training effectiveness. And lastly, future research has to consider how to integrate these novel technologies into actual training curricula. And with that, I say thank you for your attention. And if you have any questions, feel free to write me an email or visit my profile on LinkedIn.